Good morning. It's a great pleasure to give this talk at this virtual conference. And this morning I will be speaking on anticoagulation management surrounding AF ablation. Actually, let me start again. Hold on a second. Okay, I'll start again. Good morning. It's a great pleasure to participate in this virtual conference. I'll be speaking on anticoagulation management surrounding AF ablation, and I have no conflicts to disclose. What I'd like to do in the next 10 to 15 minutes is review the recommendations for anticoagulation following AF ablation contained in the 2017 HRS, APHRS, SOLI-HE consensus document. Wait, hold on a second. I need to share my screen. Okay, I'm going to try again. Good morning. It's a great pleasure to be here and to speak at this virtual conference on anticoagulation management surrounding AF ablation. I have no conflicts. Over the next 15 minutes, I'd like to review the recommendations for anticoagulation following AF ablation contained in the 2017 HRS consensus document. I'd like to provide insights as to why these recommendations were made. I would also like to provide my recommendations for anticoagulation on an individualized patient basis, and then draw things to conclusion. Now, I think we're all familiar with the 2017 HRS ERA ECAS APHRS SOLI-HE expert consensus statement on catheter and surgical ablation of atrial fibrillation. This document provides detailed anticoagulation recommendations. And in particular, if you look at the recommendations, it gives a Class 1A recommendation that for patients undergoing AF catheter ablation who have been therapeutically anticoagulated with warfarin or dabigatran, performance of the ablation procedure without interruption of warfarin or dabigatran is recommended. It also gives a Class 1 recommendation for the same recommendation with rivaroxaban, but level of evidence B. And then it gives a 2A recommendations for the other NOACs. The document also states that anticoagulation guidelines that pertain to cardioversion of AF should be adhered to in patients who present for an AFib catheter ablation procedure. During ablation, the document advises that we give heparin immediately prior to or immediately following the transeptal puncture, and that the ACT be maintained at least 300. And it recommends that protamine can be provided to reverse heparin at the end of the procedure with a 2A recommendation. The document goes on to say that systemic anticoagulation with warfarin or NOAC is recommended for at least 2 months post-catheter ablation, and that decisions regarding continuation of anticoagulation after 2 months should be based on the patient's stroke risk profile and not on the perceived success or failure of the ablation procedure. So why were these recommendations made? I think we all know that AF ablation is associated with a 0.3 to 1% peri-procedure risk of stroke. We also know that AF ablation is associated with major bleeding complications, especially cardiac tamponade and vascular bleeding. And we know that the initial strategy of stopping Coumadin with heparin bridging was shown in the COMPARE trial to result in an increased risk of both stroke and bleeding as compared with a strategy of uninterrupted warfarin. We also know that the Venture AF, AFAXA, Eliminate AF trial strategy showed that a strategy of uninterrupted, in the recircuit study, uninterrupted anticoagulation with rivaroxaban, apixaban, or daxaban is as safe and effective as a strategy of uninterrupted anticoagulation with warfarin. And the recircuit trial showed that a strategy of uninterrupted with dabigatran is superior to a strategy of uninterrupted warfarin. The anticoagulation effects of DOACs can now be reversed with Praxpine or Dexanet alpha. Now, if we look back at these landmark studies, this is the Venture AF study, the first study that was published by Ricardo Cappato back in 2015. 2017, the Recircuit trial was published in the New England Journal of Medicine, and this examined uninterrupted Pradaxa. In 2018, the AFAXA trial was published that looked at Eliquis, uninterrupted Eliquis. And then finally, we have the Eliminate AF trial that examined uninterrupted edoxaban versus a VKA. Now, of these studies, the one I'm most familiar with is the Recircuit AF trial, so we'll spend a minute reviewing that. So this was a landmark trial where patients undergoing AF ablation were randomized either to uninterrupted warfarin or uninterrupted dabigatran anticoagulation. And when we say uninterrupted, they were given dabigatran as they were wheeled into the EP lab. The anticoagulation strategy was started 4 to 8 weeks prior to ablation, continued for 8 weeks post-ablation, and the primary endpoint was the incidence of adjudicated ISTH major bleeding events during and up to 8 weeks post-ablation, and a secondary endpoint was thromboembolic and bleeding events. So this is the patient flow. We had 678 randomized patients, 339 in the dabigatran arm and 339 in the warfarin arm. The results are shown here. Patients on uninterrupted dabigatran had a significantly fewer number of major bleeding events as compared with patients on warfarin, 6.9% versus 1.6% on dabigatran, a 77% reduction in major bleeding events. If you pool all these studies together, this is summarized in this slide. So again, the combined studies are shown here. Blue is major bleeding, and again for NOAC or VKA. The light blue is ischemic stroke events, and the mortality is in gray. And you can see if you look at these studies combined, the combined endpoint of a death, ischemic stroke, and ISTH major bleeding was 4.6% with a VKA, 2.4% with a NOAC. And again, the results of all the studies were quite similar. Perhaps the most striking, showing the benefit of uninterrupted dabigatran, is the Recircuit study, but all the results were very consistent with a very strong message on the safety and efficacy of an uninterrupted NOAC strategy. So my approach is shown in this slide. All patients undergoing AF ablation are anticoagulated with a NOAC or warfarin for 3 weeks prior to ablation. If they're likely to present in AFib or have a high stroke risk profile, I prefer uninterrupted DOAC or NOAC therapy. When using an uninterrupted approach, I use Pradaxa because the availability of the reversal agent is easier and cheaper than the other agents. If the stroke risk is low and the patient's on another NOAC other than Pradaxa, I hold the morning dose or 1 dose before. If a patient prefers to be on warfarin, I perform the procedure on warfarin with a therapeutic INR, and I'm comfortable performing the procedure with an INR up to 4. I perform a CT scan to screen for a left atrial thrombus in all patients. This has been a shift in my practice plan. I used to perform TEEs very regularly, but when COVID hit, performing TEEs was difficult. CT was more available, and they have a special protocol that allows them to screen thrombus. This really allows for a much quicker and expeditious workflow. I currently only perform the TE if the CT read for thrombus is not clear, or if the patient does not get a screening CT scan, for example, if they get a cardiac MRI. I always give heparin before the TS, and my goal is to target the ACT at over 350, and I always reverse with heparin, the heparin with protamine before we pull the sheaths. In patients where a dose of DOAC was held, I restarted 3 hours post the sheath pull. All patients are anticoagulated for the first 2 months post-ablation. Patients are seen and followed at 3 months, and that's when we discuss long-term anticoagulation. Clearly, if their CHA2DS2-VASc score is 0 and they're in sinus rhythm, I'm going to stop anticoagulation. If their CHA2DS2-VASc score is 2 or more or 3 or more in women, I'm going to continue it. And if it's 1, we have a discussion about the preferences and values and also other less significant stroke risk factors such as like the calcification of the valve, left atrial size, and so forth. If a CHADS VASc greater than 2 patient or 2 or greater wants to stop anticoagulation and they're willing to accept an increased risk of stroke or undefined risk of stroke, well, I work with them to develop a strategy to minimize the risk. And this strategy usually includes the discussion of risks, twice daily EKG monitoring with the Alive core device or by checking a pulse, and the pill in the pocket approach if AFib restarts. I should note that this pill in the pocket approach is really unproven, but it's attractive and it will be studied soon in an NIH-sponsored clinical trial led by Rod Passman. So let me just conclude that AFib ablation carries with it an important risk of stroke and bleeding. Studies have shown that these risks are minimized by using an uninterrupted approach to anticoagulation. Uninterrupted DOACs are associated with a lower risk of bleeding than uninterrupted warfarin. It is for this reason that a strategy of uninterrupted anticoagulation with NOACs or DOACs is now recommended by the 2017 consensus document. All patients should be anticoagulated during the first 2 months post-ablation, and decisions to stop anticoagulation at that point should be based on the patient's stroke risk profile and not the perceived success or failure of the ablation procedure. So with that, I'll end. And again, it's wonderful to participate virtually with you in this wonderful conference. Thank you.